session is titled Patching the Petechiae, Highlights of the Consensus Statement on the Diagnosis and Treatment of Immune Thrombocytopenia in Dogs and Cats. We are incredibly grateful to have Dr. Dana LeVine joining us. Dr. LeVine is a professor of small animal internal medicine at Auburn University and is board certified by the American College of Veterinary Internal Medicine. Her clinical and research interests include immune-mediated hematologic disease, and she has contributed extensively to the recent ACVIM consensus guidelines surrounding immune thrombocytopenia. This session will take a case-based approach to the diagnosis and management of immune thrombocytopenia, also known as ITP, in dogs and cats. Topics will include the pathophysiology of ITP, diagnostic and treatment algorithms from the recent ACVIM consensus guidelines, immunosuppressive therapies, blood product transfusion, and emerging treatment strategies. So at this point, I am going to hand things over to you, Dr. LeVine. Thank you again, everyone, for joining us today, and thank you, Dr. LeVine, for being here.
Thank you so much. It's an honor to be here. I'm really excited to talk to everyone this morning. And I wanted to let people know I had to run home last minute. The IT went out at Auburn, so I'm at home unexpectedly because I didn't have internet at work. So if my dog speaks to you, I apologize. I tried to do this at work. So I'm going to talk to you today a little bit about the pathophysiology of ITP, but don't worry, I'm not going to bore you. I just want you to know enough to understand why it is such a difficult disease to both diagnose and treat. And then we'll work through the diagnosis and the treatment of ITP. And we're going to do this in the context of the two recent consensus statements on the diagnosis and treatment of ITP, which I had the privilege of being involved with. So for pathophysiology, we really don't understand why there is a loss of self-tolerance, which leads to the attack of a patient's platelets, but there is some loss, some break in self-tolerance. And we used to think of this very simplistically, that this loss of self-tolerance would lead to antibody formation to platelets, leading to their destruction by macrophages in the spleen and liver. And that does indeed happen. But we now know, at least in people, about 40% of human ITP patients do not have antibodies to their platelets, and their platelets are actually probably being destroyed by other mechanisms like T cells. And we used to think that this was just a disease of platelet destruction, where mature platelets were destroyed by macrophages of the spleen and liver. But now we know that both T cells and antibodies can target our megakaryocytes in the bone marrow as well. So this can be not only a disorder of platelet destruction, but a disorder of platelet production as well. So as you can see, this is a very heterogeneous disease where some patients can have antibodies, some patients can have T cell attack of platelets, some can have megakaryocytes being attacked, some can have mature platelets being attacked. So with that variety, it makes it clear why this isn't a simple disease to diagnose, why we can't just have one test, and why it's not a simple disease to treat either. In order to understand one of our newer treatments of ITP, we also have to understand a little bit about platelet production and what happens in ITP. So platelets are produced from megakaryocytes in the bone marrow, and megakaryocytes are mainly stimulated by a hormone called thrombopoietin, or affectionately known as TPO, which binds to MPL receptors on the megakaryocytes, which stimulates them to divide and to release platelets. When platelets age, they lose sialic acid residues and become desialated. These aged platelets are then recognized by the Ashwell-Morrill receptor in the liver, and that stimulates more thrombopoietin production. So as old platelets are cleared, more TPO is made, more megakaryocytes are stimulated to divide and make more young platelets. So that's what happens in health. What about in ITP? Well, we used to think that there was something called a MPL mass theory, where TPO was cleared by MPL receptors of platelets and megakaryocytes, but that it was made at a constant rate. So if you had less platelets, they wouldn't be cleared as much, and you should have a lot of thrombopoietin around. So we used to think that ITP patients had plenty of thrombopoietin. But now we realize what actually happens, like I mentioned, is as platelets age, they get cleared by the Asheville-Morrow receptor in health, and that stimulates the liver to make more thrombopoietin. But in ITP, where antibodies are leading to clearance of platelets by macrophages of the spleen and liver, this Asheville-Morrow receptor is being skipped, and thrombopoietin is actually not being produced as much as it should be. So in people, we now know that thrombopoietin levels are actually unexpectedly low to normal in people with ITP, and this has led to novel treatment with patients with ITP with thrombopoietin receptor agonists. However, for a long time, we did not know if thrombopoietin was low in dogs with ITP as well. And the reason we didn't know that is because there wasn't an assay to measure thrombopoietin in dogs with ITP or with any disease. And it took us many, many years in conjunction with colleagues at Cornell, Marjorie Brooks and Rob Goggs and James Catalfmo, we were finally able to develop a very challenging ELISA to measure thrombopoietin. And we were able to determine that in dogs with ITP, their dogs actually have thrombopoietin levels within the reference range. So all but 2 dogs that we studied with ITP had thrombopoietin levels at the range of healthy dogs. So it is not being produced at an increased amount to trigger more platelet production. And so this leaves room for potentially treatment of dogs with ITP with thrombopoietin receptor agonists, just like is done in people. So I promised I wouldn't go into pathophysiology too much, but those are sort of some of the newer understandings of ITP that let us understand why this is such a challenging disease to manage. And now we're going to move on to how we diagnose the disease. So a recent state-of-the-art review of ITP in people said that there's no diagnostic test, no biomarkers to direct treatment, and few comparative studies to help management decisions. So we don't know anything, and you can all have your hour back. But just kidding. But knowing that is true in people kind of made us feel a little better that we aren't so behind in dogs. But it also stimulated us to work on our consensus statement for diagnosis of ITP, where we understand that ITP is probably always going to be a diagnosis of exclusion, but we wanted to have a systematic way to be able to rule out other causes of ITP. So we wanted to be able to come up with an algorithm people could go through to come up with ITP as your remaining diagnosis. And then what we didn't know as well was when we get to the point of knowing whether you have primary or secondary ITP, really nothing had been done to establish what things in veterinary medicine could trigger a secondary ITP. So we wanted to systematically review the comorbidities that we have evidence for that could trigger ITP in dogs and cats so that we could give guidance on which ones should be looked for in a workup of a patient with suspected ITP. So ultimately, we came up with this quite complicated algorithm for diagnosing ITP. And don't worry, we are going to work through this together. But this is sort of the end product of all of the consensus statement work. We're going to work through it in the context of a dog named Nala. And I know this is kind of an old school picture, but that is actually Nala. So I didn't want to replace her by a newer modern picture. She is a 5-year-old female spayed Labrador Retriever. She went into her vet for a dental cleaning. And her pre-dental blood work surprisingly revealed that she was thrombocytopenic. She only had 19,000 platelets. Her physical was unremarkable. We were good, and we did a rectal exam and a fundic exam, and there was no evidence of bleeding anywhere. No ocular petechia, no melena, nothing. So really not clinical at all. So what are we going to do with a dog like Nala who comes in for thrombocytopenia? Well, the first thing we need to do, and this may be pretty basic, but I think it is a step that is skipped too often, is we need to make sure that that thrombocytopenia is real. So you absolutely, absolutely must make a blood smear and look at the feathered edge. And if you see a clump like this, you need to get another sample because you cannot interpret your platelet count. If you don't see a clump, then you're going to go to the monolayer and you're going to estimate the number of platelets you see in 10 high power fields. And each platelet per high power field is about 20,000 platelets per microliter. So you would want about 8 to 10 platelets per high power field for a normal animal. Cats are especially prone to pseudothrombocytopenia, this false thrombocytopenia from clumping, because their platelets get activated very easily. So if they are stressed, which most cats are during a blood draw, very often they can get platelet clumping. But it does happen in dogs too. And I will say I have been referred dogs who were on multiple immunosuppressants for what turned out to be just pseudothrombocytopenia because they were clumpers. So make sure you do your slide review. In Nala, we did, and she truly was thrombocytopenic. There are no beautiful purple dots in her blood smear like there are in this normal patient. So this is the first part of our diagnostic algorithm, that you're going to have a platelet count of less than 100,000 and that it is going to be confirmed by a blood smear. And the reason we said we wanted a platelet count of less than 100,000 rather than just any low platelet count is if you look at people, the chance of developing severe thrombocytopenia it's very low if you have a platelet count over 100,000. So the 10-year probability of developing severe thrombocytopenia in people is only about 6% if your platelet count is over 100,000. Okay, once we decide that you truly have thrombocytopenia, we then have to decide, well, is it ITP or is there another mechanism that could be causing the thrombocytopenia? And common causes would be consumption, either appropriate because your dog or a cat has had a trauma or has a bleeding mass, or inappropriate in the case of DIC. Do you have decreased production from a bone marrow disorder? Do you have sequestration in the spleen? Usually those counts don't get too low and the patients don't bleed. Or are you left with a disorder of destruction, which can be either primary or secondary? And early in our algorithm, we said that if there was obvious hemorrhage and your platelet count was over 50,000, that was probably appropriate consumption and your patient does not have ITP. But if you don't have that, how are you going to differentiate between the other causes of thrombocytopenia, the other mechanisms? And that's what led us to develop the questions that we tackled in the consensus statement. So we set up our questions in the format of PICO questions. So that means that what that means is in a population of dogs or cats with thrombocytopenia, that's our P, compared with platelet count alone, does a given test, a given evaluation, improve our ability to differentiate ITP from non-immune causes of thrombocytopenia? So we set up a bunch of questions and we systematically reviewed the literature to try and answer those questions and incorporate them into our diagnostic algorithm. The other thing we looked at a little bit in the consensus statement is are there any tests that are good at predicting disease outcome or progression? So as many of you know, platelet count alone in thrombocytopenic ITP patients does not predict whether or not they're going to bleed. So dogs and cats with ITP can have mucocutaneous bleeding, but they don't have to bleed. And one dog with 5,000 platelets may have hemorrhage everywhere, and another may be absolutely fine. So we wanted to look at different tests and determine if compared to platelet count alone, compared to being thrombocytopenic, does a given test help us determine patient's response to therapy, survival to discharge, duration of hospitalization, relapse rate, or blood product requirement? So we asked that question about some of our tests for ITP as well. So one question we asked is, does the size of our platelets help in diagnosing ITP? And the short answer is there's a lot of conflicting data in the literature. A lot of studies showed that healthy dogs, compared to healthy dogs, dogs with ITP have higher mean platelet volume or have bigger platelets than healthy control dogs. But there was one study of ITP that showed that dogs with ITP had MPVs or lower than dogs with non-immune thrombocytopenia. So the data was really conflicting, and that's not that surprising given that this can sometimes be a disorder of platelet destruction and sometimes one of platelet production. So it makes sense that different dogs are going to have variable platelet size depending on their mechanism of ITP. But what we did include in our diagnostic algorithm is that you should look out for dogs, for breeds who are known to have congenital macrothrombocytopenia and no bleeding. And if that is the case, then you probably don't need to continue to work your patient up for possible ITP. So remember, there are lots of breeds. Some of the poster children are your King Charles Cavalier Spaniels and your Norfolk Terriers, who have mutations in their platelets, beta tubulin mutations, that lead to large platelets, but they have they have enough platelet mass so that these patients do not bleed. And there have been reports of mutations in Norfolk Terriers, Cairn Terriers, a different mutation in Akita dogs. So basically, if you have big platelets and your patient isn't bleeding, what we recommend is that you do a DNA test through, and this is not my lab, I do not benefit from this, but our Auburn University does have a DNA test for looking for macrothrombocytopenia mutations. And it is worth doing that before you do a whole ITP workup if you have patients with big platelets who are not clinically bleeding. If they're clinically bleeding, then this is not what is going on with your patient. And if you go to this website, you will see that there are lots of different breeds than the ones we classically think of, in which a mutation has been detected which causes macrothrombocytopenia. Okay, what about platelet count? Does that help you determine if your patient has ITP? Well, definitely we found evidence that that dogs with ITP and cats with ITP have, and sorry, I should clarify that I am talking mostly about dogs, not because I like dogs better than cats, but because there is so little data in the literature currently about cats, mainly just very small case series. So most of our evidence relates to dogs. So that's why I'm mostly speaking about dogs, because we just don't have a lot of data on cats at all. But especially in both dogs and cats, we found that more severe thrombocytopenia was more common in dogs with ITP, but could not be used as a diagnostic test because there are definitely overlaps between groups. So a platelet count of less than 20,000 would support a diagnosis of ITP, but can't be used on its own. And here are just some examples of many of the studies we found where you can see that dogs with ITP tend to have lower platelet counts than secondary ITP or non-immune thrombocytopenia. And the same here, primary ITP is lower than secondary and lower than non-immune. But you can also see that there is overlap between groups. So some of the non-immune dogs are going to have platelet counts that are as low as the dogs with primary ITP. And there were a couple of studies that actually showed that dogs with consumptive thrombocytopenia, some retrospective studies in case series, where the dogs with DIC actually had lower platelet counts than the ones with ITP. So platelet count being quite low can make you put more weight on your diagnosis of ITP, but it can't be used alone. What about clotting testing? This is something that I feel is often skipped, and it's really important that we don't skip it. So in dogs, rodenticide and DIC, rodenticide toxicity and DIC can commonly be confused with ITP, and in cats, DIC and liver disease can commonly be confused with ITP in terms of having thrombocytopenia. And the only way that you are going to differentiate those tests is with coagulation testing. Would it be helpful to get D-dimers and FDPs? Probably, but this is not really looked at in a lot of studies, so there just wasn't a lot of evidence in the literature to support measuring D-dimers and FDPs, although ideally it would be great to have full coagulation testing. And just to give you a sense of some of the studies that supported our recommendation of doing coagulation testing in thrombocytopenic animals to rule out other causes of thrombocytopenia. There was one retrospective study of dogs with thrombocytopenia with DIC, and their platelet counts with dogs with ITP and DIC were similar, and coagulation panels differentiated between the groups. And similarly, a case series of dogs with rodenticide toxicity found a lot of those dogs were thrombocytopenic, and the way that you could tell that they had rodenticide toxicity was with prolonged clotting times. Similarly, there are several studies in cats with DIC where about 50% of the cats with DIC had severe thrombocytopenia. And the way that you're going to differentiate DIC from ITP in those cases was by measuring clotting times, where APTT was prolonged in all the cats with DIC. And then in a study we did, there was actually more dogs with secondary ITP had increased D-dimers compared to dogs with primary ITP. So D-dimers might actually help you differentiate primary from secondary ITP. And where does this come in our diagnostic algorithm? Well, early on, we recommend that you do coagulation testing when you're working up a patient with thrombocytopenia. Okay, what about bone marrow? Should we be doing bone marrow evaluations in our patients with thrombocytopenia to decide if they have ITP or not? Unfortunately, bone marrow does not seem to be that helpful as a diagnostic test unless you have multiple cell lines affected, like non-regenerative anemia or neutropenia. So we only are recommending a bone marrow if you have multiple cytopenias. And this was based on a couple of papers, although there weren't a lot of papers or literature that directly answered this question. But there was one study that looked at dogs with thrombocytopenia and their bone marrow evaluations. And if you had severe thrombocytopenia, then the bone marrows were often not diagnostically useful. So since dogs with ITP tend to have more severe thrombocytopenia, bone marrow was not that helpful in those dogs. And then many other cases of ITP describe bone marrow findings in those dogs. And they sometimes had megakaryocytes that were normal. Sometimes they had megakaryocytic hyperplasia, and sometimes they had megakaryocytic hypoplasia. So we recommend that the only time that you do a bone marrow in your workup of a dog with ITP is if they have unexplained cytopenias and you don't think sepsis is causing it. And in that case, you would do a marrow. But if you just have thrombocytopenia, we are not recommending that you go ahead and do a bone marrow. Does a marrow help predict whether or not your patient is going to bleed or have more severe disease? The data there is a little bit conflicting, and because of that, we didn't recommend doing a marrow as a prognostic test either. So in one study of 73 dogs with primary ITP, of the dogs that had had marrows performed, those that had megakaryocytic hypoplasia did not have a worse prognosis than those who had normal numbers of megakaryocytes. But there's another case series where dogs who had decreased numbers of megakaryocytes did worse. They had less survival, they needed more blood transfusions, but no statistical analysis was done in this case series. So because of this, we suggested that bone marrow analysis also is not helpful for predicting outcome in dogs with ITP. More data may come that will change our recommendation, but based on the current literature, that is what we recommend. Okay, well, if antiplatelet antibodies clear our platelets, should we be measuring platelet antibodies to determine if a patient has ITP? Well, I think if you have antibodies present to your platelets, that is going to tell you that you have an immune component to your disease, but it is not diagnostic for ITP. So we do not recommend that antiplatelet antibodies be measured routinely to work up a patient with ITP. And this is actually the question that we had the most literature to back us up on. There were actually 18 studies that provided information on whether or not antiplatelet antibody testing is helpful in diagnosing ITP. One of the best studies looked at 115 dogs with thrombocytopenia, 17 of which had ITP. And they found that if you look at IgG on the platelet surface, antiplatelet IgG, that is a very specific test for ITP, about 76% specific, but only about 30% sensitive for ITP. If you combine IgG and IgM, the sensitivity goes up to 76%, but the specificity goes down to 65%. And then this study also found when you compare dogs with primary ITP versus those with non-immune thrombocytopenia, there was no difference in the percent of direct or indirect IgG, direct or indirect IgM, or direct or indirect IgM and IgG combined. We also did a study looking at antibody levels in dogs with ITP compared to non-immune controls, primary ITP, secondary ITP, and healthy dogs. And while dogs with primary and secondary ITP had higher IgG levels than controls, there was no difference compared to the dogs with non-immune causes of thrombocytopenia. So antibodies would not be helpful in determining if the patient had ITP versus the non-immune cause. This again shouldn't be super surprising because we talked about how, at least in people, 40% of people with ITP do not have antibodies and they have T-cell mediated platelet destruction instead. And in the American Society of Hematology guidelines for diagnosis of ITP in people, they also do not recommend use of antiplatelet antibodies in working up patients with ITP because of its low sensitivity. And we know that dogs and people with ITP actually have somewhat similar disease. So this all shouldn't be a big surprise that we found that antibody testing is not that helpful. So in our algorithm, we said you could come up with a diagnosis of ITP without doing antibody testing. But if you did do antibody testing and it was positive, that was like the cherry on top. So you could diagnose ITP without antibody testing. What about does antiplatelet antibody testing help predict how your patient is going to do? Unfortunately, the answer is also no. Although antiplatelet antibodies may recur at the time of an ITP relapse, so it may be helpful in working up whether or not your patient is relapsing. So there is one study that followed patients with ITP and their antibody levels, and their admission antibody levels or how those antibody levels changed over time did not determine their response to therapy. But when those patients had a relapse, they did have recurrence of their antibodies. So again, antibody levels may help you to identify a relapse, but they otherwise probably are not going to predict your outcome. Okay, so finally, when we decide that we don't have consumptive disease, we don't have bone marrow disease, now we're left with, do we have primary or secondary ITP? And we need to know which trigger we need to investigate. So we looked, well, it was really a comorbidity task force led by Dr. Linda Kidd, looked at the evidence for different comorbidities as triggers of ITP. And they searched the literature for basically how much literature there was that directly asked whether or not a given trigger, whether or not a given comorbidity was a trigger for ITP in dogs or cats. And they rated that evidence based on a scale with integrated metric of evidence, with over 6 being high, 4 to 6 being intermediate, low, and negligible. And not having data does not mean that a given trigger does not cause ITP. It just means we don't have the papers that specifically looked at that. What we had the most evidence for was infectious disease as triggers for secondary ITP. So there was a very high level of evidence for Ehrlichia leishmania, and if you're in a place that has Rangelia, causing secondary ITP. And depending on the study, there was intermediate to high level of evidence for Babesia or Anaplasma causing a secondary ITP. And it was really hard in these studies, even if they proved that these dogs had antiplatelet antibodies, so they had some immune component to their platelet destruction. Probably other factors played a role, like vasculitis and consumption as well. So it was hard to prove that ITP was really the cause of the thrombocytopenia in these studies. We also have a very high level of evidence for certain drugs causing ITP. The ones we have the most evidence for are cephalosporins, sulfa drugs, and there was one study looking at gold salts. If you're ever going to use gold salts, it can induce ITP. But any drug can theoretically induce ITP, and it's probably underreported which drugs do. Everyone always wants to know, do vaccines induce ITP? Well, we didn't find a lot of evidence to that effect. Now, it is known that vaccines like the measles, mumps, and rubella vaccine induce a childhood ITP in people. But people have tried to prove that this occurs in dogs, and we have not been able to prove it. There was actually a recent study since the consensus statement that looked at 150 dogs with ITP compared to over 600 controls and looked at whether there was an increased rate of vaccination in the last 30 days in the dogs who had ITP versus controls, and they could not find any. So we have not been able to prove that vaccines cause ITP in dogs or cats. But we've all had anecdotal experiences where we know it can happen. What about cancer? The highest level of evidence that we found for cancer was in solid tumors. So there is some evidence that solid non-hematopoietic tumors can cause secondary ITP. There was one study that we couldn't give a rating for, couldn't give an integrated metric of evidence for, but it looked at which autoimmune disease might be cause an increased risk of developing lymphoma. And the only autoimmune disease that had an increased risk of causing lymphoma was ITP. Dogs who had ITP had over 5.6 odds ratio of developing lymphoma. So that was kind of asking the question in the opposite way, but there may be an association with lymphoma and ITP. So what does this all mean? How are you going to take this what was developed with these integrated metric of evidence for comorbidities? How is this going to change your approach to a patient with ITP? We're going to get a good travel history, a very good recent drug history. If you are the emergency clinic seeing a dog with thrombocytopenia, you absolutely need to ask, did you have a UTI recently? Your dog have a UTI recently and get put on Clavamox or cephalosporins? So you have to ask a good drug history. You have to know whether they've been exposed to ticks, what their preventative status is. You want to do good CBC and biochemical profile to see if that points you towards an underlying disease. Don't forget your clotting testing. Imaging, depending on the age of the patient and how much likelihood you think there could be neoplasia, or if your biochemical profile pushes you that way. And then you're going to do infectious disease testing based on what you have in that area, knowing that there is a higher level of evidence for Ehrlichia, Anaplasma, Babesia, Rangelia, and Leishmania. And something that is important is that if you have a patient where you suspect there could be infectious disease, you want to make sure you combine PCR with serology. And the reason is that early in the disease, you're going to have more antigen and be more likely to be PCR positive. Later in the disease, you'll have less antigen circulating and be more likely to be antibody positive. And there's actually a study that showed that if you combine PCR and serology, you have a 58% increased sensitivity of diagnosing a vector-borne disease. So make sure in areas where you have these vector-borne diseases that you're combining PCR and serology to rule out your tick-borne disease. The last thing I just wanted to mention about diagnosis of ITP is not part of the consensus panel, but something that we have found in our own research. So CD61 is an antibody to part of your fibrinogen receptor on platelets, to the GP3A part of your fibrinogen receptor. And it's used in a lot of flow cytometric studies to just identify a platelet. And previous studies have reported that dogs with ITP lose their CD61 expression. And that is something that we have seen as well. And we recently did another study of dogs with ITP compared to dogs with thrombocytopenia of other causes. And here is primary ITP versus controls. You can see our primary ITP dogs lose CD61 expression. And it also holds up in comparison to dogs with other causes of thrombocytopenia. Just to give you a sense of what this looks like by flow, this would be a normal healthy dog with tons of CD61 staining on the platelets. That's the orange. And this is a dog with ITP, where you can see how little orange, how little CD61 staining that there is on this dog with ITP's platelets. We actually looked at whether or not loss of CD61 could be a good test for ITP. And this is basically an area under the curve analysis where an AUC of 0.5 is no better than chance, and AUC of 1 is perfect. So an AUC of 0.761 is pretty good. And using this analysis, we said that if your CD61 expression was less than 8%, you had the test was 68% sensitive and 82% specific for diagnosing primary ITP. So it may be that CD61 could be added to our toolkit for diagnosing primary ITP. So let's just apply this to our friend Nala. How do we go through all this? Well, first we needed to confirm that Nala actually was truly thrombocytopenic with a blood smear. We do a CBC and chem to see if she has any other systemic disease we should chase, a urinalysis, which was normal. We absolutely do our clotting testing, which was perfectly normal. She was a middle-aged lab, so we did want to do imaging, which was also normal. We did a 4DX. Are you guys happy with a 4DX? Based on what I told you, hopefully the answer is no. We really should be doing a comprehensive tick panel, especially if you're in an area like I am now in Alabama where you have tons of tick-borne disease. So you want to do PCR and serology combined. If you are in a frozen tundra, I met Nala in Iowa, in the middle of winter, a 40X might be sufficient. And in Nala, just to show you what this would look like, we also did platelet antibody testing. Again, not essential, but I wanted to show you what it would look like. So this is isotype control for IgG. This is Nala. All the green that's above the gray is positive, and this is IgM. Negative is the gray, and orange is her, and that is all positive for IgM. So she had increased amounts of IgG and IgM on her platelets. So that would be like, oops, sorry, she had the cherry on top of our diagnostic algorithm. Okay, before we move on to treatment, just to summarize, ITP, like I told you, it's a very heterogeneous disease. And our prediction of outcome and diagnosis are challenging because of that. We have to work to differentiate ITP from non-immune thrombocytopenia. We want to follow our diagnostic algorithm. Don't forget our coagulation testing, plus or minus antiplatelet antibodies. Don't forget to do your comorbidity testing to differentiate primary from secondary ITP. And then maybe there is a new role for the CD61 testing in diagnosing ITP. Okay. Treatment. So we're going to work through cases, a mild case, a severe case, and then we'll talk a little bit briefly about refractory disease. And all this again will be based on the consensus statement where instead of PECO questions for treatment, we ask PICO questions. So in a given population of patients, those with ITP in this case, we wanted to know if a given intervention being studied, a given treatment, compared to not giving that treatment, improved outcomes for these patients. And then we also asked some, and that was based on extensive review of the literature. And then we also asked some non-PICO questions of our evidence evaluators where we knew there wasn't going to be any literature or evidence, but we wanted to at least develop some guidelines based on the experts on the consensus panel's practice habits. And ultimately, we developed an algorithm similar to what I showed you for diagnosis of ITP, although it's a lot simpler than the diagnostic one. And we're going to work through this on the basis of a couple of cases. So first, we're going to look at a stable patient, like our friend Nala, where she had 19,000 platelets per microliter. She had no obvious bleeding, but we know that if you have less than 30,000 platelets per microliter, you are at risk of spontaneous bleeding. So we definitely are indicated to begin immunosuppression, and our mainstay of therapy is going to be glucocorticoids because they're the fastest acting thing that we have. So we want to do 2 mg per kg of pred per day. Although if you're a big dog, we recommend dosing on a mg per meter squared basis. And then depending on where you are, you want to start doxycycline pending your tick panel. And just to point out, there was actually a recent paper that determined that 5 mg per kg twice a day is more effective at clearing Ehrlichia than at 10 mg per kg once a day. So I recommend the divided lower dosing. And we're going to keep on that dose of glucocorticoids until we're in remission and then taper slowly over many months. If you have severe GI bleeding or a patient who's not eating well, then I would convert the oral prednisone to dexamethasone by dividing by 10. Do we want to add a second immunosuppressive medication? That's another question we asked. Does adding a second immunosuppressive medication improve outcomes? And basically the short answer is no, it does not. So what we recommended, well, we don't know. Based on the data, we do not know. There's no evidence that adding a second agent improves outcomes. So we recommended as a consensus panel that if you don't see a response in a week, to start a second agent. If you expect you're going to have side effects from glucocorticoids, like you're diabetic or you have heart disease, to add a second agent. If you relapse during your taper, to add a second agent. Or large dogs we know do not tolerate steroids very well. So if you're over 25 kids, we recommended adding a second agent up front, or if you have severe bleeding. And the drugs we recommended, which we'll talk about in a minute, are azathioprine, cyclosporin, leflunomide, or mycophenolate, in no particular order. And just so you can see, there were several studies that tried to ask the question of whether a second agent improves outcomes, The problem is none of them were prospective, none of them were randomized. They were all retrospective, they were all underpowered, and often there were multiple second agents used in a given study, so really hard to interpret that data. So just because we don't have the evidence a second agent helps doesn't mean it doesn't. We just don't have the studies that are appropriately designed. In cats, similarly, there's no evidence, so our recommendations were similar to dogs. If you're not responding, if you expect you're going to have severe side effects or not tolerate glucocorticoids, if you relapse during your steroid taper, add a second agent, or if you have severe bleeding. And then the drugs we recommend in cats are either cyclosporin or chlorambucil. How are you going to decide if you think your patient has severe disease? Well, some of the best evidence we have is if you're bleeding somewhere scary, if you're bleeding into your lungs or your brain, if you have severe anemia requiring a transfusion, or if you have GI bleeding. And the GI bleeding is based on one study of 73 dogs with primary ITP. If you did not have GI bleeding, 90% survival to discharge. If you had melena or increased BUN, only 60% survival to discharge. So we know that melena is a negative prognostic indicator in ITP and probably deserves adding a second agent up front. We also have a bleeding scale called the Doggy Bat, where you basically grade your bleeding at different anatomic sites based on none, mild, or severe. And you get a total score, a Doggy Bat score. And a study found that as your Doggy Bat score increased, your blood product use increased, and your duration of hospitalization increased. And it may be because GI bleeding is a component of the Doggy Bat score, and that may be the reason that Doggy Bat correlated with outcome. But Doggy Bat may give you something else to base your measurement of disease severity on. All right, I said I'd talk about whether any second agent is better than any other. Again, we don't have the data. So we don't know. We just recommend either using azathioprine, cyclosporin, it should be modified, luflenamide or mycophenolate in dogs with ITP. There are no prospective studies that prove that one of those agents is better than another. There is one retrospective study of dogs with ITP where dogs who received either glucocorticoids and cyclosporin or glucocorticoids and mycophenolate, and there were no statistics done. They did the same survival-wise, but the dogs with cyclosporin tended to have more adverse effects. Again, retrospective study and no statistics done, so take that with a grain of salt. One thing I did want to mention that a lot of people don't know is that cyclosporin is, at least in the South, associated with opportunistic fungal infections. So in a study that looked at dogs with different immune disease, using cyclosporin versus other drugs had a 7 times increased risk of developing secondary infections compared to other medications to treat the disease. And we really do see this. So cyclosporin in Iowa was my favorite second agent. Now that I'm in Alabama, I'm scared of it. This is Sophie. She actually had PIMA, not ITP. She didn't respond to other drugs and then had a great response to cyclosporin, but then she developed systemic black mold or curvularia and ultimately did die. So in the Southeast, we do warn owners about secondary infections with cyclosporin, and we do use other drugs as a priority to cyclosporin if we can control the disease that way. If you live somewhere cold, have fun with cyclosporin. It's a great medication, but just make sure you warn your owners in the warmer areas where we have these opportunistic fungal infections. Wanted to mention briefly that I feel pretty strongly about not triple immunosuppressing. In this study that looked at 73 dogs with primary ITP, the one dog that got cyclosporin and mycophenolate and steroids did statistically worse, died. Obviously, it's only one dog. But in my clinical impression, you're going to have more benefit if you switch out your second agent, and you're just going to increase your risk if you keep adding on more immunosuppressants. So I really stay away from triple immunosuppression. If cyclosporin's not working, I might switch to mycophenolate, but I'm going to try not to triple up. In cats, we recommended either using cyclosporin or chlorambucil. Just know that you should never use azathioprine in cats because they can't metabolize it. We didn't list mycophenolate because there's just not a lot of data on mycophenolate in cats. And we prioritize cyclosporin over chlorambucil only because chlorambucil has been associated with chronic thrombocytopenia when it's used in lymphoma in cats. So for our friend Nala, Nala did not have any markers of bleeding severity, so no reason to add a second agent for that. She had no bleeding at all. However, she's a big girl, and we know from some studies that big dogs do not tolerate glucocorticoids as well as small dogs. So we did add a second agent up front in her. Now, Nala did very well. She responded very quickly, but her vet, every time she tried to taper her prednisone to under 10 mg per kg per day, or sorry, 0.3 mg per kg per day, 10 mg per day, her platelet count would fall to about 100,000. So she was kept on 10 milligrams, not 10 mg per kg, 10 milligrams total per day for 2 years. And when I actually met Nala, this is what she looked like. She actually had the worst calcinosis cutis that our dermatologist had ever seen. And Nala made us ask some questions in the consensus statement about what our treatment goals and definitions of treatment success should be. So in human medicine, they actually recommend not treating a patient if your platelet count is over 30,000 with ITP and there's no bleeding. So we wanted to know, what should we be happy with and what should our treatment goals be? So we said no response would be less than 30,000 platelets with bleeding after 2 weeks of therapy. Partial response would be having a platelet count between 30,000 and 100,000 with a twofold increase from baseline. Complete response would be over 100,000 and no bleeding. And a full response would mean that you were at over 100,000 and stayed that way without treatment. We recommended, while we didn't think we could say 30,000 was safe since we can't tell our patients to be quiet, we recommended that the treatment goal should be a platelet count of over 100,000 with no evidence of bleeding. So that really changes how we think about things. And for Nala, it meant that we could start to taper her therapy and reduce her dose by 20 to 25% every 3 weeks and just make sure that her platelet count stayed above 100,000, which it did. Okay, changing gears. What do we do if we have a scary bleeder? This is Izzy. She came in, of course, on New Year's Eve. She had 3,000 platelets, came with epistaxis, and had lungs that looked like this. So we're obviously in a different place with her. Now we are looking at having a high doggy bat score and severe bleeding. We have to think about transfusion, and we need to think about adjunct therapies. We would certainly want to add a second immunomodulatory drug, and we need to think about whether or not we want to add vincristine or IVIG. So basically, we recommend in dogs with severe bleeding that we want to either give vincristine or IVIG, but we prioritize using vincristine because it is more cost effective than IVIG. However, we cautioned in the dogs with ABCB1 gene mutations to be cautious with vincristine and maybe prioritize IVIG in those cases. So vincristine, just as a reminder, is going to paralyze your microtubules in your megakaryocytes, which is going to lead to premature platelet fragmentation and increased platelet release from the bone marrow. It may also inhibit platelet phagocytosis and interfere with platelet antibody production. There is good evidence that using vincristine compared to prednisone alone leads to shortened hospitalization and a quicker time to a platelet count of over 40,000 platelets. A similar study was done for IVIG and found that if you give IVIG and pred compared to pred alone, you have a shorter hospitalization and a quicker time to platelet recovery. And then somebody smart decided to compare vincristine and IVIG, so pred and IVIG, or pred and vincristine, and they both did as well, except that IVIG cost about twice as much as vincristine. So that is what led to our recommendation of prioritizing vincristine over IVIG in dogs, at least ones that do not have the ABC mutation. And then in cats, just to note that we actually changed our priority in cats, and this was just based on a few case series where cats did not seem to respond to vincristine as well. So we recommended that cats, we prioritize IVIG over vincristine in cats with severe ITP. Again, based on just a few case series, so not really good evidence-based literature. What about transfusions? Should we be transfusing our patients with ITP? Well, if they just have a low platelet number, there is no evidence that giving them a platelet transfusion is going to improve outcome. But if they are bleeding somewhere life-threatening, like Izzy was into her lungs, we would definitely want to transfuse. And what are our options? We can either use fresh whole blood, we could use platelet-rich plasma. If you're a person, you're going to get fresh platelet concentrate. We could use chilled platelet concentrate or frozen platelet concentrate, the DMSO stabilized platelet concentrate, or freeze-dried platelets, but those are not currently available, unfortunately. That is stable plate. I want to just point out that I mentioned chilled platelets and I mentioned whole blood that's stored for under 14 days. And there is some new evidence in both human and veterinary literature that stored chilled platelets may be as efficacious as fresh platelets. So this is a study in people undergoing cardiopulmonary bypass surgery being randomized to either get room temperature or chilled platelets. And the study is ongoing. There's no data yet. But basically, it's seeming like chilled stored platelets may be more rapidly cleared, but they're actually probably more procoagulant than fresh platelets. And there is some recent data in the veterinary literature showing that you can store platelets in the fridge for up to 14 days and they're still going to be hemostatically active. So just wanted to point that out because I've been really excited about using stored whole blood, and we keep whole blood in our fridge at Auburn. And if it's within 14 days, we think that the platelets are still viable and we will give that to our ITP patients. In terms of which platelet product is going to be best, really, there is no data. So it's what you have available, what's safe, what volume your patient can tolerate. Okay, just wrapping up at the end here. What do you do if your patient doesn't respond? If you do all these things and they are still not responding? Well, the first thing you want to do is make sure, is your diagnosis right? Are you giving the right drugs? If yes, you truly have ITP, you go back through your algorithm, you haven't missed anything. If you haven't added a second agent, do that. If you've given vincristine, consider giving IVIG. And then there are a couple of other options. I let you guys know that thrombopoietin is inappropriately normal in humans and dogs with ITP, and thrombopoietin receptor agonists are used routinely in human patients with ITP. What about in our patients? We don't have a lot of evidence. The best paper was actually just a 5-case series of dogs who had not responded to other treatment, and 4 of the 5 dogs responded to a TPO receptor agonist called rimiplostim. However, these TPO receptor agonists are really costly. So if they weren't as costly, we might recommend using them sooner. But with the limited evidence and the cost so far, we recommend using the TPO receptor agonist in patients who are refractory to disease or where they're not tolerating their immunosuppressants. I want to point out that you don't want to use eltrombopag, which is a human TPO receptor agonist that has been proven not to bind to megakaryocytes in dogs, so it just won't work. It won't be harmful, but it's just going to be a waste of money. What about removing the spleen? Is that helpful? Splenectomy is something we can consider in patients who have refractory disease, as long as we very carefully ruled out vector-borne disease. Otherwise, we're going to make things worse. And it's something to consider if they're not responding or if they are not tolerating their immunosuppression. When we looked at all of the literature in the consensus statement, almost all dogs who had splenectomy survived to discharge. Now, all of these are case series. They are not controlled randomized studies, so you have to interpret them in light of that. About 10 out of 23 dogs had a complete response, 4 had partial response, 7 relapsed, and 2 didn't improve. So I think splenectomy in a refractory patient is very reasonable. When you finally have control of your disease, you're going to want to taper your immunosuppressive drugs by 25% every 2 to 4 weeks, making sure your platelet count is stable and staying above 100,000 at the time of each taper. And then you can either stop your second agent abruptly, or I prefer to taper that as well. What if you have a relapse during your taper? If it is late on and you were diagnosed a long time ago, it's reasonable to work the patient up and make sure they don't have a different disease now. If it's just early in your taper, what I usually do is if they are just having a mild relapse, I'll go up to my previous dose of glucocorticoids. If they're having a severe relapse, I'll go back to 2 mg per kg per day. And if they are not on a second agent, I will add that at this time as well. One question that always comes up is, what do we do with vaccines? Is there any evidence that vaccination is going to trigger a relapse? And there really isn't a lot of evidence to this effect. So unless we really think that vaccination was our trigger for a given patient, we recommend to weigh the pros and cons of disease exposure versus potential of relapse. If you can, do titers in your patient. If it's a cat, keep the cat indoors. And I just wanted to point out there was actually a recent study that looked at whether or not vaccination is going to trigger relapse in your patients. And this study actually found that of 14 dogs with ITP that were vaccinated, none of them relapsed. So again, it's small numbers, but we don't have a lot of evidence that vaccine is going to trigger relapse. So overall, we just recommended that you do titers where you can. Don't vaccinate until you're at least down to 0.5 mg per kg per day of pred, or they won't respond, ideally off your second agent. Separate vaccines, do only what you think your patient, vaccinate for only what you think your patient is at risk for getting, and after each vaccine, to check platelet counts 2 and 5 weeks post-vaccination. And that brings us, we have completed and worked through all of our diagnostic or treatment algorithm now for what we do in a simple case, a case with severe disease, and a refractory case. So to conclude, for treatment of ITP, you want to treat cases differently, treat them according to their severity. Your goal is to be over 100,000 platelets per microliter, not normal. We really, to understand what is going to be the best treatment, need prospective randomized controlled trials to decide which second agent is better. Does splenectomy help? Do thrombopoietin receptor agonists help? And the more we understand about how the disease occurs, the better treatments we're going to have. And I just want to make sure to thank all of my consensus statement panelists. I couldn't have done this without them. And we had 40 evidence evaluators who helped us go through the literature from across the world. And so thank you to them as well. And at this point, I will take any questions.
Thank you so much, Dr. LeVine, for such a great session. Very informative. I feel like I've learned quite a bit. And I know we really appreciate you taking the time to share your expertise with us. I'm seeing some questions pop up into the chat here. So I have our first one here from Lisa. How do you feel about using melatonin?
That is a great question. And let me see if I have I have a couple of slides, but basically I am not a proponent of melatonin because it can be both an immunomodulator and an immune stimulant. And melatonin was looked at in healthy dogs and didn't do anything to platelet crit or MPV. So there's not a lot of evidence it does much. And if it's going to be an immune stimulant, I worry about that. So I just don't think we have the evidence yet. So currently I don't use melatonin and I am not recommending it. And that's what we said in the consensus statement. If somebody does a study and proves me differently, I'm happy to be wrong. But based on our current data, I just don't think we have the information.
All right, thank you. And I have another one here from Jacob. Does the increased NPV alter how you read a blood smear and or count platelet per power field?
Okay, great question. So does MPV influence your platelet count? It shouldn't. It's going to influence your platelet crit, but it shouldn't influence your count. There's a chance if the platelets are big enough, it might like really abnormally big. It could throw off your automated CBC machine, but usually not for how big just a platelet gets in ITP. It shouldn't throw off your count. That's a good question, and definitely shouldn't throw off your manual count. It should actually just make it much easier for you to see those platelets when you're looking at your smear.
Right. And our next one here is from Jessica. How do you feel about use of aminocaproic acid?
That's a great question, and I didn't mention it. I think aminocaproic acid can be helpful. I don't think we don't have data to say that it is useful, but I think it is a great adjunct. There was one study that looked at tranexamic acid in dogs with ITP, and it did make them vomit, and they didn't show any obvious benefit, but it was a small study. I prefer aminocaproic acid because I think it's better tolerated, and I think if you have a very severe case, I don't think there's any reason not to use it. But again, just something we don't really have a lot of data for. So I think it's safe.
Oh, yeah. I had one as well, just from a transfusion medicine perspective. Are there any misconceptions around blood product use in ITP patients that you commonly encounter?
Well, something I hear from the students a lot, which probably won't be this audience, but a lot of them think plasma has platelets in it. So that's one thing I hear. So plasma, regular fresh frozen plasma is like the one product that has no platelets in it. I think the other misconception people have is they say, well, whole blood's not going to really raise your platelet count a whole lot, and that's true. But it is going to get your platelets to the site of bleeding and can be absolutely life-saving. So I'm not looking at whether my transfusion is going to increase my platelet count by a certain number, especially with like we found out when we had stable plate and the lyophilized platelets, it didn't change the count that much, but those activated platelets went to the site of bleeding and did what was needed. And I think that's what we're going to see a little bit with the cold stored platelets too. They're going to be a little more primed and probably just go where you need them. So that's a common misconception. I just don't fret about how much it's going to increase my count. I think your standard dose of whole blood can really be life-saving. I've seen it do it in some severe GI bleeds. I've even seen it help in a brain bleed. And I've just found it so helpful to have the cold stored whole blood because now we don't need to call in a donor at 2 in the morning to donate fresh whole blood. I just make sure we have positive and negative whole blood in our fridge at all times. And if it's under 14 days, it can be used for platelets. Great
Perfect.
question. Thank you.
Yeah. And then I have another one here from Jacob. Does the demographic of New England, where it is really cold and hot, dependent on the season, change your approach on use of cyclosporin?
Um, well, I did train in New York, not in New England, but I think we really do have less opportunistic fungal infections up there. So if I weren't in the Southeast, I think I'd be much more comfortable with cyclosporin again. I think I mean, you probably know better than I do practicing there, but really it's the Southeast where we see these just gross, opportunistic fungal infections. So I probably wouldn't worry as much, in the, Northeast as I do down here.
Right. Yeah. All right. And then I do have one more question here from Rebecca, who's really curious if you know of stable platelets coming back.
Yeah, that's a great question. I think there is hope that so Bodivet, the company that has the rights to it, is willing to give those rights to someone else. I think it's just whether or not it's going to be cost effective for somebody else to produce it because it's an expensive product to make, and is the price point for what people are willing to pay going to exceed that enough to make it worthwhile for a company. So I think that's where things stand. So I think there's a possibility. I think the more that we learn about cold stored platelets being possible, where you could at least keep platelets in the fridge for 14 days, may defeat somebody's desire to generate a product like that again, whether it'll be profitable enough.
Right.
But I love it. I wish it would come back.
I know, I know. It was very popular when we had it on our shelves
Yeah.
too. All right. All right. So it looks like that's all of our questions for today. And I just want to say thank you so much to everyone that came to join us, and for your continued interest in transfusion medicine and continuing education. I know the certificates of attendance for the session will be distributed following over the next week or so. If you have any questions at all following today's webinar, please feel free to reach out to the Canadian Animal Blood Bank team. We're more than happy to help answer them. And then just as a final note, if your clinic is interested in becoming more involved with canine blood donation, whether through donor recruitment, awareness, or potentially hosting donor clinics, we'd absolutely love to connect with you. Expanding access to canine blood products across Canada really, truly depends on the collaboration with all of us in the veterinary field. So we're really grateful for clinics interested in supporting transfusion medicine initiatives. But yes, I hope you all have a wonderful rest of your day, and we look forward to seeing you at the next session.